5. So, plus 7 days. So, July 12. And of course, you add 1 year. So, 2021. So, okay, here's another example. What if your LMT is January 10, 2022? So, compute, count back 3 months. So, December, November, October. And then 10 plus 7 is 17. So, of course, hindi na mag-add ng 1 year kasi yung October 17 ay nagpo-fall naman within 9 months from your LMT. Okay? Nag-get nyo? So, ano na lang siya, isang parang for me common sense na lang siya kung magdadagdag ka ng plus 1 in the year. So, hindi naman necessarily, that's why I didn't include it here, hindi necessarily mag-add ka ng 1 year. So, you count back 3 months, you add 7 days, and then depends kung nasa latter part of the year or nasa early months yung LMT mo, if you will add plus 1 or you will retain the year for your EDD or your estimated due date or date of delivery. Okay, so we have another case. We have a patient named Inday. She's 31, nalipa growth. So P0, okay? P0 si patient. So hindi natin alam kung buntis store hindi. Hindi natin nabigay. Basta nalipa siya. So P0. Her chief complaint is spotting. So when you ask her about her LMT, she can't give you an exact date. Pero when you press for it, ang sasabihin sa'yo, I think Doctora, around November last week. Okay, so ano ang una mong gagawin? This is a very basic question. Lahat ng residente, tatanungin ko sa inyo. Which diagnostic test should you order first? Simple. Urine pregnancy test. It will matter kung buntis or hindi yung patient. So this is where, after the age, gravidity parity, this is the next part of the algorithm. Any reproductive age woman presenting to you as abnormal, with any abnormality sa pagdudugo, pregnancy test. Whether hindi siya dinudugo, meaning amenorrheic, or kapag may abnormality sa pagdudugo niya, like may spotting in between menses, or sobrang lakas ng menses, pregnancy test. Doktora, wala po akong pakipagtalik, hindi yan nagpa-positive. Syempre, hindi mo pwedeng pilitin yung patient, but you have to explain to the patient na, ma'am, magmamatter po kasi siya sa management natin kung kayo ay pregnant or hindi. Ginagawa po siya sa lahat po ng pasyente na nagre-regla pa rin po na may abnormality po sa pagdudugo. Okay? Sa vaginal bleeding. Pag nag-represent ang vaginal bleeding. Okay? So just explain what to the patient na kailangan siyang gawin kahit nagde-deny yan ng pulso. Okay? Hahanapin kasi talaga yan ng pag-referan nyo na OBGYN, yung pregnancy test. Okay, so 31-year-old, nalipa never had a pregnancy beyond 20 weeks, may spotting. So, okay, sakta lang, tama, nag-pregnancy test naman si intern or si clerk. So, next question. So, sabihin natin yung positive si Inday. So, G1P0 na siya. So, which hormone does your pregnancy test? So, redundant, no? So, which hormone does your pregnancy test for? Tama pala. So, basically, ano yung hormone na dinidetect niya? So, what it's testing for, whether sa urine or sa serum, okay, is your beta HCG. Note the alpha letter before your human chorionic gonadotropin. It's the beta subunit, okay, of your HCG. Yun ang dinidetect ng pregnancy test. Okay, board exam question. Okay, favorite. So, the following statements regarding beta HCG are true, except, so, alin dito ang false about your beta HCG? So, isa-isahin ko ha, for you. First, its alpha subunit is similar to that of your TSH, LH, and FSH. So, these hormones, these are your other pituitary hormones. So, second, it declines after 10 to 12 weeks and plateaus at after 15 weeks. So, by 15 weeks, nagpa-plateau na siya. Is that true? Third, it is mainly produced by the corpus luteum until the placenta takes over. So, last, it may be detected in the maternal serum or urine 8 to 9 days after ovulation. So, this is around 3 weeks after your LMT. So, ito ba ay, alin dito ang tama, alin ang mali? So, let's talk about the beta HCG because this is a very important hormone for us. So, your human chorionic gonadotropin or your HCG has 2 subunits, your alpha and your beta subunit. Now, your alpha subunit, yung subunit na yon shares a similar structure with that of LH, FSH, and TSH. Meaning, yung alpha subunit nitong hormone ito, same lang siya with that of HCG. This is the reason why yung beta, yung tinetect natin. Kasi siya yung unique sa HCG. Nag-get? Okay, so urine test and serum assays test for the beta subunit, as I mentioned. It may be detected in the urine and serum 8 to 9 days post-ovulation. So ito medyo highfalutin, ito hindi nyo ito magigit. Pero ito siguro. Ito importante to. If you are watching out for pregnancy or if you are anxious right now if you're pregnant or not, kailan siya magpa-positive yung urine pregnancy test, yung PT kit na makikita mo sa Mercury or in your convenience store. So it will test positive around the time of the missed menstrual cycle. What do I mean by this? So for example, my LMP is December 15. I'm regular naman. Pagdating ng January 15 the next year at hindi na ako nagkaroon, or January 17, or basta around this time, pag hindi pa rin ako nagkakaroon ng menses and I know that I'm sexually active, I will do a pregnancy test, okay? Magpa-pregnancy test ako because it will already show you a positive result if you are pregnant. Very rare yung mga false positive results ng pregnancy test. So kapag halimbawa faint lang, minsan faint lang yan eh. Kahit faint na line that's already considered negative, hindi yan mag-show up in any form kung ikaw ay hindi pregnant, okay? So kahit super faint na second line, positive yan, that's considered positive. Okay, hindi kailangan ganito ka-bright red yung test line. Alright, so saan na-perform yung anong produce ng HCG? The one that produces your HCG is your placenta, okay? Your syncytial trophoblast are the ones that secrete your HCG. So ano ba ang point ng HCG? Basically, your HCG, its point is to maintain the corpus luteum. Okay, so ano si corpus luteum? Si corpus luteum, basically, kapag nag-ovulate ka, siya yung matitira sa dominant follicle mo. Okay? Siya yung parang wrapping, for lack of a better term, kumbaga siya yung surrounding structure around your ovum, your egg. So kapag na-release mo na yung egg, what remains inside the ovaries is your corpus luteum. Now, corpus luteum is very important because it's a temporary endocrine structure, meaning naglalabas siya ng hormones for a short period of time. So, yan, as I mentioned, placenta produces the HCG. Ang point lang ng HCG is to make sure that the corpus luteum lives. Why is the corpus luteum important? Kahit pinagkubaran lang siya ng egg. It is important because it produces your progesterone. And your progesterone is the one that maintains your pregnancy. Isipin nyo guys, bakit hindi kami nag-opera ng mga ovarian new growth ng less than 6 weeks, mga nasa first trimester? It's because we are afraid of violating the ovary with the corpus luteum. Kasi kapag tinanggal namin pag na-dilate namin yung corpus luteum, you will be withdrawing progesterone. And what will happen is you could abort the baby. So progesterone is important in maintaining the endometrial milieu that is suitable for your pregnancy. Nag-get? Okay. So yun ang point lang basically ni HCG. So si corpus luteum, eventually 6 weeks, mag-degenerate na yan. So sino na ang mag-produce ng progesterone? So after 6 weeks, unti-unti nang nag-take over yung placenta. So as your gestational age develops, your placenta also develops, nagiging siya na yung main source ng progesterone. So okay na, pwede nang i-dispose ng body yung corpus luteum. Okay? But in the meantime, kailangan i-maintain ng placenta through HCG, yung corpus luteum, the main source of this one, this very important hormone, progesterone. If you've ever had threatened abortion in your lifetime, or kung may patient kayo na merong threatened abortion, note na most of our therapeutics are given in the form of progesterone, either iniinom or intravaginal progesterone. So that's how important progesterone is. Okay, so other notes about HCG. So it doubles every 48 hours in a normal pregnancy. So kapag halimbawa, exponential kasi ang growth nito eh. So for example, today, I test my beta HCG. After 2 days, kung normal yung pregnancy ko, dapat kung 1,000 ngayon, magiging 12 siya. Magiging 2,000. And after another 48 hours, times 2 ulit. So 4,000, ganun, etc. Okay, I'm not very sure with the particular values. We have a table for that in the OB Platinum. Okay, please support. Okay, so pero so halimbawa, nag-beta HCG ako ngayon, tapos 1,000. After 48 hours, bumaba, 800 na lang or even 1,000. So magiging worry ako na baka hindi viable yung pregnancy ko. Baka hindi to normal pregnancy. Kasi ang expectation mo is every 48 hours, dapat nag-double siya. Okay? So this is important kapag wala kang makita sa ultrasound, tapos pero biochemically buntis ako. Ano ako doktor eh? Sinong HCG? Meron. CT? Meron. Bakit walang naman yung na-test ko? Bakit walang adnexal mas? Walang ectopic? So for pregnancies of unknown location, this is an important clinical correlate. This fact that the HCG doubles every 48 hours. Okay, so this peaks at 10 to 12 weeks, and it declines to reach a steady state after week 15. Some references, they will say 15 weeks magpa-plateau. So essentially, kapag week 15, week 16, nagpa-plateau na yan. Okay, so this is the value, 100,000 milliIU per ml. Sometimes this is reported as IU per liter. That's the same lang. By 10 weeks, then it will level off around this time in the third trimester. So as I mentioned, the placenta produces HCG to maintain the corpus luteum. So very important, very important. Do not forget that fact because that makes letter C the one incorrect statement here. So tama naman to, alpha subunit is similar to the other pituitary hormones like your thyroid hormones, your LH, FSH. So tama to, kami-mention ko lang ito. Anong mali dito sa statement na to? It is produced dapat by the placenta. Okay? So ang dinidescribe actually ng letter C is your progesterone. Okay? So it is produced mainly by your corpus luteum until your placenta is old enough to take over in the progesterone production. Okay? So ito, tama din to. So guys, around the time of menses, if you are sexually active, walang mawawala kung mag-pregnancy test. Okay? Just to make sure that you are not pregnant. Okay, so sige, same pa rin, same patient, same diet, 31-year-old newly gravid. So these are the components of your psychosocial sexual history. So you know the vices, smoking, drinking, alcohol. Later on, I will tell you why I highlighted this kasi may mga important aspects about the vices that we need to take note. Religion. So this is important kasi OB is a bloody business. I forgot which page in Williams that is stated, pero kapag Jehovah's Witness po, as you know, we can't do blood transfusion. So it's one of the important notes that you have to take into consideration when you do psychosocial and sexual history. That's why we ask this. So other things that you can ask are patient educational attainment, occupation, so sa sexual history, first coitus. So bakit importante yung first coitus? Kasi di ba pag halimbawa malapit sa menarche, ikaw nag-first coitus, so very prone kayo na magkaroon ng persistent HPV infection, or kapag halimbawa yung number of sexual partners mo ay marami, so that predisposes you also to HPV infection. So important din to ask if the partner of your patient is promiscuous or non-promiscuous. Okay? And also history of STD or your sexually transmitted diseases. So kapag meron silang history nun, you ask kung ano yung mga naging prior treatment nila. So that's important. Contraceptive use, this is also important for us. Nag-pills po ba kayo nanay? Nag-injectable po ba kayo? Nag-IUD? Okay? So yun yung mga tatanungin natin. So that will also change our management. So for example kasi, naka-DMTA yung patient mo for 1 year. Ang chief complaint niya sa'yo ay spotting. So immediately, alam mo na agad. So you know that DMTA, one side effect is that there could be spotting. Isa yung sa mga nireklamo nila. Kasi pag may naka-injectable ka, your endometrium becomes atrophic. So kumbaga kumikisis yung anterior and posterior endometrium, that is why there is spotting or bleeding. Breakthrough bleeding when you have, when you're being given DMTA or your injectable. So important, take note of that. So other things to know. So in terms of vices, pag buntis yung patient mo, you know that smoking predisposes your patient to a lot of disorders. Okay, I have a question for you. Okay, lahat di ba? Marami kang kalaban if you're a smoker and you're pregnant. So you can have stillbirth, placenta previa, preterm delivery, etc. Medyo given na to kasi kumbaga papangit yung uteroplacental milieu mo kapag ikaw ay nagsusmoke kasi may hypoxic, may hypoxia component. Pero what is the one thing? What is the one disease na instead of what do you call this? Na hindi siya risk factor. Ironically, hindi siya risk factor. Sometimes sinasabi pa nila protective. What is this one disease na okay ka? I mean, na hindi ka magkakaroon, you're less likely have if you're smoking. So ironically, ang smoking is not a risk factor for pre-eclampsia. Okay? That's a very interesting fact. So parang siyang endometrial cancer. Protective pa siya against endometrial cancer. So yun din yung something unique, something that might be asked in the board. If you're smoking ironically is not a risk factor for your pregnancy-induced hypertension or your pre-eclampsia. Okay? Sometimes protective pa siya. You don't know the reason why. May mga postulates about it, but basically yun siya. Kung baka kasi ninyo walang pre-eclampsia dito, kahit expect mo siya, di ba? Smoking, hindi mas likely kang mag-high blood. But no, in the books, both in blueprints and in Williams, smoking is not a risk factor. In fact, it could be protective against your pre-eclampsia. Okay, your fetal alcohol syndrome, isa dito sa mga favorite questions namin. So there is a triad for your fetal alcohol syndrome. So if you drink during your pregnancy, especially during the embryonic period, so that is until 8 weeks from fertilization or 10 weeks AOG, you will have this triad. First, growth restriction. Second, facial abnormalities. May specific fascies na to, pero sige, I will leave that up to you for your reading. And CNS dysfunction. Okay, so that's your triad for your fetal alcohol syndrome. So huwag kayong inom ng wine, especially during the organogenesis, especially during the embryonic period. Okay, bawasan yan. This is also the reason why kapag nakainom ka, first trimester mo, hindi mo alam buntis ka, nag-New Year's Eve party ka. So pag ganito, pag na-elicit yung sa'yo ng OB mo, ipapa-congenital anomaly scan ka niya during your second trimester to look for these things in your baby, okay, in your fetus. Illicit drug use, so these are the things, these are the comorbid conditions that are predisposed to when you have illicit drug use. Okay, so next part. So tapos ka na sa psychosocial history ni Inday, now we go to the menstrual history. So para maalala namin yung menstrual history, we use the mnemonic MIDAT. M stands for menarche. Obviously, this is the age during the first menses. Next is the interval. Usually, pag hindi naman kami OC, we write regular monthly intervals. Meaning, your menses has an interval or days between 28 plus minus 7 days. So why did I put this 24 to 38 days? Kasi kapag yung resident mo ang tinanong niya sa'yo, o sige, based on the FIGO revision na AUB definition, ano na dapat yung mean interval mo? 24 to 38 days is the new normal. Pero itong 28 to plus minus 7 days, this is easier to remember. For me also, this is easier to remember. Also, this is still in the chapter of your Compre Guide, 8th edition. So nung residency ko, 7th edition pa, there is a new edition that came out last year, I think. So 20 to 7 plus minus 7 days, this is still in textbook. So the duration of flow, ito pa rin, nasa Compre Guide 4 to 7 days. But if you will base it on the FIGO, 2018 revision, less than or equal to 8 days. So for the amount, this one, I agree with FIGO on this one, okay? So nasa book 35, it would be up to 60 ml, but this is difficult to quantify unless talagang mini-measure mo yung naka-menstrual cup ka, di ba? But usually, hindi mo ito maka-quantify as a patient or even as a doctor. This is very hard to quantify. So the amount is based on FIGO guidelines. This is patient determined. Depende sa pasyente, how it affects your daily living, kung ano yung perception niya. So usually the patient would describe it as heavy, normal, or light. So ito na yung bagong consensus namin. It's patient determined na the amount of menstrual blood flow. And of course, the symptoms. The most important symptom is dysmenorrhea, or dysmenorrhea is defined as pain associated with the menses, especially during the first day of menses. So ano pa ba yung other symptoms? So pag may pelvic endometriosis ka and you have endometriosis in your rectum, you can have dysphagia. Doktora, pag nag-menses ako, napansin ko talaga, masakit tumae. Okay? Sakit mag-poop. Or doktora, pag time ng menses ko, tapos nagkipagtali kami, masakit makipagtali, dyspareunia. Or doktora, nagkaka-UTI ako, basta may menses ako, sure, masakit na hapde umihi, dysuria. So when you see those Ds, you're probably dealing with a patient with pelvic endometriosis. Pelvic endometriosis, meron kang aberrant endometrial glands or endometrial tissues in areas aside from your endometrium. Okay, so I will discuss that in the gyne part. Okay, pero basically, ang importante ni active symptom is this one, the symptom of dysmenorrhea. Okay. Alright, so when do you, so FIGO guidelines, guys, ang AUB is either kulang sa menses, sobra ka sa menses, or hindi ka nag-menses at all. So when do you investigate? So ito guys, this is based on Compre Guide, the latest edition, and also based on ESRM. So ESRM is the American Society for Reproductive Medicine. So if you have no menses by the age of 15, I'm mentioning the source kasi malilito na naman kayo pag nag-aral kayo sa word 16 years old kasi ito sa blueprint. But okay, for your rotation, 15 years old, okay, in the presence of secondary sexual characteristics. Ano yan, doktora, yung secondary sexual characteristics? These are your breasts, your pubic hair. So kapag meron ka nun, and you're already 15 years old, you're still not menstruating, you have to be investigated for a source or a cause of primary amenorrhea. When you say primary amenorrhea, never had menses in her lifetime. Secondary is kapag nag-mens ka and then it stopped for a certain period of time. Okay? So these are the times you have to investigate. Also, if hindi ka pa nag-mens from the telar or from the time that your breast buds began to develop, if this happened before 10 years of age. Okay, so ito, hindi naman siya AUB, hindi naman siya amenorrhea, but if wala ka pa rin breast development by the age of 13, you have to have your investigation for primary amenorrhea. Nag-get? Okay, so 15, 13, and 5 years from telar. So these are the instances when you have to investigate. Alright? Okay, now we have a new patient for you. Mag-move on na tayo from the previous patient. So we have Joy, she's 38 years old. She's a G5, P2, 1122. Okay, so ginawa ko mas complicated yung kanyang OB score para mas may na-discuss tayo. So when you see obstetric history, iba pa to sa obstetric score. Yung obstetric score mo, overview mo lang yun. Kanina mo lang yung parang part yun ng general information for us ng patient. When you see OB history, hihimay-himayin natin each pregnancy. Okay, so what we take note of is the year of the pregnancy, the AOG, sometimes enough na for us na term, kung term lang naman. Pero kung halimbawa preterm, pwede note for us kung gaano ka preterm. Bakit importante kung gaano ka preterm? Kasi sa next pregnancy mo, pwede maulit na around that AOG. Halimbawa 28 weeks, nag-deliver ka na, pwede kaming sa next pregnancy mo, mas worry kami na, mag-28 weeks na to, baka mag-preterm labor na naman to. Okay, so that's important for us. Next is the mode of delivery or the procedure done on the patient. Next, place of delivery. Okay? So important to time, especially if you have questions regarding your case, etc. Okay, next is the outcome or the status of the baby. May complications ba itong baby? May sakit ba yung baby? Living ba itong baby from this pregnancy? So si Joy, ano ba ang kanyang complicated OB history? So isa-isahin natin. So for our G1, it was in 2012, sir. Okay, so more than 37 weeks. The mode of delivery is NSD or normal spontaneous delivery. Sometimes they call this SBD or spontaneous vaginal delivery. Sa kwenta ko lumabas yung anak ko, first pregnancy. Sa PGH po ako nanganak. Buhay naman po nung pinanganak, buhay pa rin siya ngayon. Wala naman po complications. Yung baby na to, walang naging komplikasyon. Yun lang yung wala kang komplikasyon na pagbubuti. Okay? Yung second pregnancy ng G2, this was in 2015, around 8 weeks, spontaneous abortion. Why do I need to say na spontaneous? May bang non-spontaneous? Guys, unfortunately, there are cases of induced abortion. Okay? So spontaneous abortion naman ng 8 weeks, pero hindi naman po ako niraspa. Okay? Binubulan po ako, hindi po ako niraspa. No 2018 preterm, halos sabihin natin 8 months, ganyan, around 32 weeks. Mode of delivery, primary low transverse cesarean section. Para saan po kayo ng CS? For placenta previa. Okay? Ako, kapag nag-explain ako sa pasyente ko, ang ginawa ko pong cesarean section sa inyo, pasmile po sa ilalim ng portion ng matres nyo. Ibig sabihin, around 18 months from now, kapag nagbuntis po kayo, pwede po kayong mag-normal. Okay? That's one of the reasons why the mode of delivery, the time of delivery, and the CS score is important to note. Magbabago to kapag siya ay mayroong classical cesarean section score. Hindi ka na pwedeng mag-VBAC or vaginal birth after cesarean section. So that's just one of the things na important kung bakit kailangan kong inote kung anong klaseng operative technique for your cesarean section and ano yung indication. Why? Pwede nga ulit yung indication, di ba? Pwedeng may placenta previa siya ulit sa next pregnancy niya. So saan ginawa ko? Saan po ginawa yung CS nyo? Sa hospital ng Makati. Ano po nangyari dun sa baby? Buhay naman po. Live birth, buhay hanggang ngayon. Kulang po siya sa buwan, tapos yung baby ko po nalaman na meron po siyang sakit sa puso. Okay? May butas po siya sa puso. So this is important to note. So other diseases na pwede mong i-elicit or pwede ma-elicit, doktora, yung baby ko po may hydrocephalus, yung pangatlo ko. Or doktora, meron po siyang pinabifida. So yun mga important yun, no? Magmamatter yan sa mga succeeding prenatal check-ups ng patient mo. Next, pregnancy, 2019, nag-ectopic pregnancy siya on the right, sa PGH ulit siya na itakbo, and for that, natanggalan siya ng right fallopian tube. So these are the things that are important to note. And currently, nitong sumunod na year, 2020, she's already pregnant. So since hindi mo alam yung status, it's enough to note na current pregnancy, yung G5. So let's check the OB score, tama naman, G5, no? P2, because you have a term, you have a preterm. These were both carried beyond 20 weeks. One term, one preterm, two abortions, one abortion, continuous abortion, and one ectopic pregnancy, and two kasi buhay, CG1 and CG3. Okay? I hope that's clear. So other parts of your OB history na important din i-go. Prenatal check-up history. Ilang beses po kayong nagpa-prenatal? And saan po kayo nagpapa-prenatal? Itong patient na to, okay, I will try, hindi ako magpapagalit, pero dapat naman sa hospital siya magpapa-check up, no? Kasi meron siyang, kasi scarred uterus ang tawag namin dito. Meron siyang previous cesarean section. So, dapat sa hospital, instead of lying in and health center, magpapa-check. Kasi sila yung makakapag-manage sa patient when the patient delivers a term, okay? So, ito yung mga important na i-note sa prenatal history. Okay, now we'll go to the physical examination. So medyo mahaba yung yung history taking namin, but basically the important notes there are that you don't mention female, you mention the age, the gravidity parity, and what's important for us is that you will also include the obstetric history, the menstrual history, sexual history. Okay, yun yung mga important namin. Aside from your HPI, past medical, family medical history, kung napansin nyo, hindi ko na dinaanan yun, no? Kasi those are parts of your history taking that are not unique to OB. What's unique to us, what we really put premium on are your OB history, menstrual history, ayan. Kailangan thorough kayo dun sa mga things na yun. Kasi yun yung mga unique to our specialty. Okay, so now we'll move on to the physical examination. So for this, hindi ko na masyadong ito-toxic yung pag-chest PE. Okay, so those are important. Those are important. Let me tell you that. Yung head and neck, okay, yung mga ganun things important. But let me focus on the pertinent PE that we look for in our OB patients. Okay, so let's move on. So first, general survey. So yung usual lang yan. Awake, conscious, coherent. Ayan. So same lang naman as other specialties. Okay, not in cardiorespiratory distress. And next is your vital signs. So I highlighted this because I would like to highlight one disease entity kasi very common to. So babalikan ko to. So vital signs are usual. Your blood pressure, heart rate, respiratory rate, temperature. We look those. And during this time, pati O2 saturation, we already look at those things now. Next is the height and weight. Okay, so we look at this kasi tinitingnan namin yung weight din nila, especially second trimester above. Okay, so tinitingnan namin how they gain their weight. And then the BMI, we compute it based on the pre-pregnancy weight. Okay, kasi syempre obviously, obesity or overweight, if you base it on their current weight, if they're in the second trimester or the third trimester. So we compute the BMI based on the pre-pregnancy weight. So next is, one important note for us is abdominal examination. So focusing on the abdominal examination, these are the things that we look for: the stomach height, the fetal heart tone, and your loopholes maneuver. Okay, so ito yung mga special parts of your physical examination that we do as obstetrician gynecologists. So next is your pelvic examination. So another unique thing na I think kami lang yung gumagawa routinely. Internal examination, when you insert 2 fingers into the vagina. You can also do your rectovaginal examination, although this is not routine sa mga OB patients, more of the gynae conditions. Pag OB patients, enough na for us yung IE findings. Next is your speculum examination. So you use the speculum to visualize the cervix and the vaginal walls of your patient. Later on, we will show you a video with the speculum examination and pelvimetry. Okay, so this is another important aspect of the physical examination. Yung pelvimetry, I will discuss this later on as a labor kasi mas ma-appreciate nyo siya in relation to labor. Okay? Next. Okay, so as I mentioned, why do we take note of the weight of the patient? Kasi meron tayong normal na weight gain. So in the second to the third trimester, normally if your pre-pregnancy BMI is normal, dapat mag-gain ka ng 1 pound per week. Okay? So kung nakita mo yung patient at 24 weeks, next consult niya sa'yo, 28 weeks, dapat nag-gain siya ng 4 pounds. Okay? So note nyo guys, kaya naka-blue to, kaya naka-highlight to, you will find this table in Williams. Kaya siya naka-highlight kasi parati siyang tinatanong. For normal BMI, for patients with normal BMI, this is for the entire pregnancy na ha, 25 to 35 weeks, that's your average weight gain. Madali lang yung maalala. So the rest, I will leave that up to you. Okay, just take note guys na hindi to yung Asia Pacific BMI. Mas strict sila sa Asians, okay? 23, pag pumata ka ng 23, 24, you're already overweight. Diba? Ganun sa Asians. Between 25 to 30, you're already obese 1. Diba? Kung papansin niyo dito, overweight pa lang yun. So, this is for Caucasians. For Asia Pacific, it's mas maliit yung BMI cutoff, okay? Pero yung nasa book, and yung itatanong sa iyo sa board, this one, kung ano yung sa Caucasians, kung ano yung nasa Williams. So, ang normal weight gain mo, average weight gain mo during pregnancy, if you have a normal BMI pre-pregnancy, it's 25 to 35, okay? 1 pound per week in the second to third trimester, that's the normal weight gain, okay? Okay. So, why did I highlight vital signs a while ago? So, ang unang mong iti-take sa patient na vital signs, siguro sabay mo nagagawa iti-take na important na we look at is the blood pressure. Okay? So, bakit? Bakit important yung blood pressure? So, we have what we call pregnancy-induced hypertension. So, that's your gestational hypertension and your preeclampsia. Now, we have a strict criteria for gestational hypertension. If you reach a BP of greater than or equal to 140/90, this is or diastolic of 90 without proteinuria, meaning wala kang end-organ damage. It doesn't manifest as proteinuria, which is seen on urinalysis most of the time, occurring after 20 weeks gestation, and BP levels return to normal 12 weeks postpartum. This means that you have gestational hypertension. If you have proteinuria naman, 140/90, on 2 occasions, ito din guys, sa 2 occasions din to, at least 4 hours apart. Tingnan yung BP criterion nila. Beyond 20 weeks in a woman with a previously normal urea. So these are your parameters for proteinuria. Either nag 24-hour urine collection ka, and you saw that on 24-hour urine collection, meron kang at least 300 milligrams of protein or albumin in your 24-hour urine collection. Pwede rin nag-swap ka urine protein and creatinine ratio, and the ratio of that is at least 0.3, or kapag sa urinalysis mo, may dipstick of at least +1. So ito yung tinatawag ng mga OB na stat alb. Okay, pag stat alb mo nga ito, 140/90. Ang hinahanap namin doon is ito, yung dipstick result. So if it's at least +1, you have proteinuria. That means you have proteinuria, ibig sabihin hindi ka na gestational hypertension. So next, 140/90, na walang proteinuria beyond 20 weeks, GH or gestational hypertension. Kapag may proteinuria, pre-eclampsia. Ngayon, ano ang culprit mo behind these hypertensive disorders? The culprit here is your placenta. Okay? So ang culprit mo bilang placenta, ang culprit, ang number one, actually ang only treatment na definitive for your pregnancy-induced hypertension is delivery of the placenta. Okay? So yun lang ang gamot sa pre-eclampsia. Kailangan ma-deliver yung placenta. Okay, so another note about pre-eclampsia. Ngayon, hindi lahat ng pre-eclampsia may proteinuria. Pwedeng negative to lahat ng tatlong to. But in the absence of proteinuria, pag na-fulfill na yung BP criterion, plus meron siya nitong any of the following. These are called severe features. Okay? thrombocytopenia or platelet count less than 100,000, renal insufficiency, so high creatinine, impaired liver function, specifically twice elevated. But you could have, like, kung 35 ang normal na cutoff mo per AST, pwedeng 40, okay, hindi pa yan yun. Dapat twice elevated or 70 and above. Or unexplained right upper quadrant or epigastric pain, you will think of impaired liver function. So that's a severe feature. It's part of your preeclampsia syndrome. So next is pulmonary edema, cerebral or visual symptoms such as headache or visual disturbances. Okay? So I probably highlighted this kasi siguro nagamit ko to in a previous question, no, na may patient siguro ako na both with pulmonary edema and visual disturbances. So kahit wala kang proteinuria, pag mataas ang BP mo, meron ka nitong any of these things, you label the patient as preeclampsia with severe features. Pag halimbawa naman, wala nitong criteria na to, meron na siyang BP, elevation with proteinuria, preeclampsia without severe features. So dati, requirement sa amin kung proteinuria. And the reason why they removed it from the criteria, from the strict criteria of your preeclampsia, is because sometimes hindi nagmamanifest yung patients with preeclampsia ng proteinuria, pero may iba na siyang evidence of end organ damage, such as thrombocytopenia or renal insufficiency. Actually, mas malala yung end organ damage na pinapakita niya. So pag ganyan, takot na kami pag sinabi ng patient sa amin, high blood siya, doktora, nalabo yung paningin ko. Sakit ng tikmura ko talaga, sobrang sakit. Matakot ka na. Baka you're dealing with impending eclampsia na pag ganyan. Okay? So as I mentioned, this is considered severe preeclampsia with severe features. Sorry, we don't label severe preeclampsia kasi walang mild preeclampsia. So we want to emphasize that, no? Hindi na siya mild preeclampsia and severe preeclampsia. Preeclampsia is a spectrum of disease that we only have with or without severe features. So another criterion for preeclampsia with severe features is the presence of an abnormally high BP greater than or equal to 160/110. So kung ito hinihintay namin at least 4 hours apart, ito kahit within seconds lang nga or within minutes, kapag confirm talaga namin na 160/110 yung highest BP niya, we already label the patient to have severe preeclampsia with severe features. Okay, so bakit important na i-label kung sino yung may severe features, sino yung without severe features? Yung mga without severe features na preeclampsia and gestational hypertension, we don't need to give them prophylaxis for seizure. So ito masakit to guys, masakit siya for the patient, sobrang init sa katawan nito. So we are very worried. Okay, hindi, it's not without side effects. Yung iba na nag-magnesium sulfate toxicity, they can present to you with DOB or difficulty of breathing. So we really choose the patients to whom we give magnesium sulfate. So we only administer magnesium sulfate if the patient has severe features or the patient already went into eclampsia. Okay? Kaya sa pre-eclampsia, prior to eclampsia, so ito yung ayaw sana natin, no? Yung seizures na hindi mo ma-explain ng other etiology that could only be explained by your pregnancy-induced hypertension, that is what we want to prevent or what we want to mitigate with your magnesium sulfate. Okay? So this is our treatment as well as our prophylaxis for your seizures. Okay, so as I mentioned already, eclampsia, this is the occurrence of seizures or convulsions that is not explained by anything else. So this is seen in patients with hypertensive disorders of pregnancy. Yung chronic hypertension, pwede yung patient is diagnosed before 20 weeks or if it persists after 12 weeks. Bakit? Sabi ko nga sa inyo, diba, the reason why the patients are having preeclampsia or pregnancy-induced hypertension is because of the hormones coming from your placenta. Kaya siya lang yung treatment mo the delivery of that is the only treatment for for the preeclampsia or gestational hypertension. Ngayon, if na-diagnose ka na high blood before 20 weeks AOGC, 17 weeks, okay? Na-diagnose ka na high blood ka, 150/100 ka. Chronic hypertension tawag doon. Kasi hindi mo siya masisisi sa placenta. The placenta is not mature enough or it's not producing enough hormones for it to be the culprit behind the pregnancy-induced hypertension. In the same way, kaya siya nagpo-persist after 12 weeks kasi beyond 12 weeks, hindi mo na yan masisisi sa placenta. Okay? Hindi mo siya pwedeng sisihin na, high blood ako kasi pre-eclampsia ako eh. Tapos 6 months na postpartum. High blood ka na talaga, ma'am. Yun lang po talaga yun. Okay? We have to accept that. Ayan. Inulit ko lang pala siya dito. Okay. Prior to pregnancy, this is first diagnosed after 20 weeks pero persistent after 12 weeks. So magkaiba yun, no? Pwede naman na on monitoring, pwede naman na-diagnose ako 24 weeks pero upon monitoring, beyond 12 weeks, I'm still high blood. I probably need chronically hypertensive already. So meron din tayong chronic hypertension with superimposed preeclampsia. So hypertensive na ako baseline, meron pa akong preeclampsia. So what's at fault here is my lifestyle disease or my baseline hypertension. On top of that, pati yung placenta ko is making my BP so high. So ano ba yung qualifications mo for this? Yung onset or worsening baseline hypertension accompanied by new onset proteinuria. That's why if you have a chronic hypertensive patient, important na meron kang baseline 24-hour urine collection. Okay? Kasi we take note of that in your as you progress in your gestational age, or if there are other findings of end organ dysfunction that is not present prior to pregnancy. So these are the qualifications for you to be labeled as a patient with chronic hypertension with superimposed preeclampsia. Doktora, pwede po bang chronic hypertension with superimposed preeclampsia without severe features? Pwede. Meron din chronic hypertension with superimposed preeclampsia at malas ka with severe features ka pa. Pwede din yun. So hindi porke you have superimposed preeclampsia, you're already labeled as severe with severe features. Kailangan hanapin mo pa rin ito. So severe features na to or the BP criterion of greater than or equal to 160/110. Malinaw? So hindi porke chronic hypertensive with superimposed preeclampsia, nag-magnesium sulfate na hindi siya automatic. Okay. So what's important about yung mga management, yung nitty-gritty nun, sige, I'll give that up to you. You have to read the CTG. We have a very good CTG for hypertension in pregnancy. For this one, I want to impart with you, importante to, timing of delivery. So as I mentioned, importante na ma-deliver yung placenta. Pero hindi naman pwede diba anytime lang kasi you have to patient here. So you have to balance the good of the baby versus the mother. Kung meron siyang presence ng end organ damage. So dalawang binabalance mo dito. This is a balancing act. Siyempre hindi ka pwede mag-deliver ng 2 preterm baby. Hindi ka rin naman pwede magpatanggal ng mother just because you want to keep the baby, to mature the baby longer. So for gestational hypertension and preeclampsia without severe features, pagpatak niya ng term, meaning pagpatak na ng 37 weeks, you already have the right to induce labor, okay? I-admit mo na yan for delivery. So huwag kayo magtataka kung i-admit kami GH, gestational hypertension lang, hindi naman nag-labor, ano ba yung pinapabantay pa ako ni doktora? We have to deliver these patients at 37 weeks to avoid further end organ damage to the mother kasi pwede kang mag-progress to preeclampsia. However, in the presence of severe features, 34 weeks, whether you have preeclampsia with severe features or whether you have preeclampsia at chronic hypertension with superimposed preeclampsia, basta may severe features, may karapatan ka nang mag-deliver at 34 weeks. So ito yung consensus namin na each of the station na it's relatively safe to deliver a preterm baby, and at the same time, ito yung perfect timing din para hindi naman mag-progress to having an organ damage yung mother. Now, eclampsia regardless of the AOG of the mother, since nag-seizures na, ito yung pinakaayaw nating ma-reach na point for the mother, we deliver. Okay? Regardless of AOG. Ito, important to chronic hypertension na uncomplicated lang siya. So, hindi mo masisisi ang high blood placenta. So, if you determine your patient to have just hypertension, then you can prolong the pregnancy up to 38 weeks. So, para bakit mas matagal pag chronic hypertension? Yung tagal na nga ng high blood. Exactly. This is because sanay na yung body ng mother nakapag-adapt siya to an environment of high BP. Okay? A hypertensive environment. Kung pwede ka pang maghintay. So, well-adapted na siya doon. Pero kapag chronic hypertensive with superimposed preeclampsia, basta preeclampsia, gestational hypertension, that's pregnancy boost, that's because of your placenta, deliver at 37 weeks. Malinaw? Basta may severe features guys ha, 34 weeks. Yung medyo papatagalin mo lang na pwede mong patagalin ng konti. Chronic hypertension na uncomplicated. Well-controlled BP, walang superimposed preeclampsia, walang severe features yan. Pwede yung tumagal, 38 weeks. Beyond that, baka ma-judge tayo kapag hindi tayo nag-admit and induce ng patients. Okay? Na high blood. Okay, so next part of your P is your fundal height or your fundic height. So around 20 weeks to 34 weeks AOG, kung ano, yung fundic height mo, that roughly correlates in centimeters to your gestational age. Meaning, kapag 20 weeks yung baby ko, around 20 centimeters yung fundic height ko. So this is measured along the abdominal wall from the top of the symphysis pubis, so may bony, sa bony pelvis, I will show you later on a picture, to the top of the fundus. That is your fundic height. So prior to measuring your fundic height, you must ask the mother na, mami, ihi ka muna. So bakit so important? Una sa lahat, you'll be pressing on the symphysis pubis. So baka maihi siya kapag nag-start ka doon ng measuring tape. Second, pwede niyang mas-increase yung fundic height mo if your bladder is not completely empty. So paihiin niyo muna sila prior to taking your fundic height. Pahigain niyo sila sa spine on your examination table, like so. So this is how you take your fundic height. So there is a bony part there sa ano nyo, sa above your mons pubis, and you look for the tallest point of your fundus. That is your fundic height. So 20 to 34 weeks, important din yung na-note. Mamaya, may question ako regarding that. Bakit important yung i-note? Kailangan sa ulo niya siya. 20 to 34 weeks, your fundic height or your fundal height in centimeters roughly correlate to the gestational age. Okay, so, Doktora, ito pa, is actually sa patong way to note the gestational age kapag hindi talaga niya alam. Pero nakatamo yung height ng fundic height sa may umbilicus. Meaning, around 20 weeks AOG yung patient. So, you know na kapag 12 weeks, beyond 12 weeks, nagiging abdominal organ na siya above the pelvic rim, umaangat na yung uterus mo. So, pag sinabi mo 12 weeks for precise, ibig sabihin, nakakapa na siya beyond the symphysis pubis. So, this is just an estimation, you guys. So, more of clinical eye and clinical PE talaga, and correlate talaga to, guys. Pero ito ang pinaka-importante siguro, si 20 weeks, kasi siya yung pinaka-notable na anatomic landmark. Kapag nakakapa mo na yung fundus mo sa level ng umbilicus, your corpus size, your AOG, is around 20 weeks. So, between the symphysis pubis and your umbilicus, 16 weeks. So, there is, i-fundic height ko na yan, beyond the umbilicus. Okay? So maganda din siya. Actually, yung corpus size, minsan ginagamit din namin siya, ginagamit talaga namin siya pang describe ng size ng mate. So if you have myoma uteri, you are free to label your corpus na or your uterus that is enlarged to 20 weeks. So pag gets na namin, hanggang sa fundus yung uterus ng patient. Okay? Nagets niyo guys? So importante din to. Importante siya later on pag nag-ask ako ng questions regarding this. Okay, so give for instances when your fundic height is greater than your AOG at 20 to 34 weeks. So una, you could be dealing with a large baby, macrosomic baby. Sometimes tandem yan. Most of the time tandem to pag diabetic yung baby mo. Huwag sa macrosomic, pwede marami siyang water or marami siyang amniotic fluid or polyhydramnios. So tandem siya sa gestational diabetes mellitus because diba, pag diabetic baby, they have a tendency, pag diabetic yung mother, you have a tendency to have central obesity or truncal obesity in your babies. May, disposition, may, basta na sa store, sa truncal area, yung fat. So you have a macrosomic baby, you have a big baby greater than the 90th percentile for that gestational age. At the same time, para kang may, di ba, ang mga diabetic adults, they tend to have polyuria. Ganun din sa babies. So the more na umiihi yung baby, the more na dumadami ang amniotic fluid because your amniotic fluid is mostly composed of your urine, your fetal urine, beyond the second trimester to the third trimester. So usually combo yan. So ito yung unang iisipin. Baka yung baby or sobrang daming tubig, kaya mas malaki yung fundic height mo ng dihama compared with your gestational age. Next, ano pang isipin mo pag sobrang laki ng fundic height mo compared with your AOG? You could be dealing with a multifetal gestation. Baka hindi lang isa yung baby mo, hindi lang yung singleton. Baka may twins ka, di ba? Second, you could be dealing with smaller pregnancy. So isa to sa mga pertinent PE, isa to sa mga iisipin mo kapag sobrang laki ng corpus size niya, ng fundic height niya compared with the computed AOG that you have. Ano pa? Siyempre, kapag may myoma yung patient, kapag meron siyang ovarian new growth that you could mistake for the fundus, pwede mo siyang makapa as increased fundic height. So this is the fourth instance na naiisip natin kapag meron kang fundic height that is greater than your AOG. In the same light, going back to the macrosomic baby, kapag ang fundic height mo naman is more than 3 centimeters na less than your AOG, so yung kabalik na naman isipin mo. You may be having a very small baby. Pwedeng SGA yan paglabas or may dahil meron siyang intrauterine growth restriction. So let's go to this next question. So you have an 18-year-old pregravid, 32 weeks AOG. She has preeclampsia with severe features. Note na she is a young pregravid. So isa yan ang dalawa ang kanyang risk factor dito. She's young pregravid, second she's pregravid. So it's her first time to be exposed to your placental tissue. So that's the immunogenic theory behind placenta behind preeclampsia. So if it's your first time to be exposed, you're pregravid, you're more likely to have preeclampsia with severe features. Okay, so ang importante dito sa question 10 na to is that 32 weeks na siya pero tingnan niyo naman yung fundic height 28. Remember, di ba? Ang 20 to 34 weeks dapat nagko-correlate si fundic height and AOG. So what you are dealing with here is a probable case of intrauterine growth restriction. Okay? So hindi siya lumalaki na baby. So anong risk factor nito ni patient? Meron siyang preeclampsia. So hindi maganda yung uteroplacental unit niya. She could be having uteroplacental insufficiency secondary to her high blood kasi instead na vasodilated, vasoconstricted yung kanyang vessels in her placenta. So hindi nag-grow ng tama si baby. Okay. So So as I mentioned, yung pubic height is correlating well with your AOG around this time. So alin dito yung expected findings mo sa IUGR? So isa-isahin natin from the bottom. Okay, her estimated fetal weight is less than the 10th percentile, so that is consistent with your IUGR. Abnormal Doppler findings. Your Doppler findings, guys, nagpapa-Doppler tayo if we are wary of uteroplacental insufficiency. So warranted yung patient, diba? Because she has hypertension. So kailan ka pang mag-Doppler? Other instances na pwede kang may uteroplacental insufficiency, pwedeng diabetic mother, pwedeng meron siyang APA. Okay, so any disease or comorbid conditions ni mother that would predispose her to having uteroplacental insufficiency, that's it, okay? Magpapa-Doppler tayo. Kasi hindi to left and right ginagawa. For a normal pregnancy, you don't order Doppler. So abnormal Doppler findings, okay, that's consistent with your intrauterine growth restriction, especially in the background of preeclampsia. No increase in estimated fetal weight after 2 weeks. Yes, okay, that is also consistent with your IUGR. Second, yung first, abdominal circumference is larger than the head. So meron kasi tayong tinatawag, guys, na brain sparing. Kapag may intrauterine growth restriction ka, or actually in the presence of an injury to the baby, like in the cases of your uteroplacental insufficiency, there is what we call brain sparing, meaning the fetal circulation in particular, prioritizes the circulation to the brain. Kaya sa brain sparing, you spare the brain from hypoxic injury. So dapat, ang mas malaki is the head circumference compared with the abdominal circumference. Nag-get? Okay? So dapat kung may IUGR ka, yung head yung mas malaki than your abdominal circumference. So the correct answer here is letter A. Okay? Nag-get? Okay, so next, this is one important maneuver for us, your Leupold's maneuver. So important to for us because this tells us the lie of the baby, whether transverse or longitudinal or oblique, and also this tells us the presentation as well as it leads us in terms of determining where to find the fetal heart tones, okay? Where to find the fetal heart tones and to engage yung baby natin. So that's how important your Leupold's maneuvers are. So usually when you report this, L1, L2, L3, L4, because you have 4 Leupold's maneuvers. So si L1, we start by palpating the fundus. So si L1, ang dinedetermine niya kung anong fetal part ang nasa fundus. If you palpate a large nodular mass, that means that the fetal breach is at the fundal part, okay, at the fundus. Meaning, ang nasa baba mo is your head. Cephalic yung presentation mo kung yung breach yung nakakapa mo dito. Pero kapag ang nakakapa mo sa L1 is a hard, round, mobile, balotable mass, it means na yung fetal head yung nasa fundus. Doktora, may kailan nagiging balotable. Ano po yung balotable? Okay, balotable means that when you press it down, it will bounce back up. Okay, yun ang balotable. So mapipili mo yan kapag ulo yan, kapag pwede kasi yan, hindi yan balotable. But if it's your head, it's balotable. Ano pong significance ng doktor yung balotable? So anyway, kaya nagiging balotable guys because your head has your cerebrospinal fluid, your CSF. That's why it is balotable on your L1 or your Leupold's maneuver 1. Okay, so your next Leupold's maneuver is your L2. So kung papansin niyo yung kamay, yung hand, yung palm, ay nasa side ng mother. So there are different ways of doing it. Sabay ko siyang ginagawa. But others, they will teach you na kapag when you do your L2, yung isang hand stationary, tapos yung ikakapa niya yung other side, yung contralateral side. And then you do the same. So ito naman yung stationary, ito naman yung kakapa. Pag nagmamadali kayo sa ER, sinasabay ko na siya guys. Ang important na kasi talaga dito is you will know kung nasaan yung hard resistant structure that is convex. So yun yung important. Alam mo na fetal back yan. Ito, this is very, pag nakapag-Leupold's maneuver 2 kayo, it's very telling. Okay, it's very telling. Kasi yung ibang minsan malilito ka sa fetal part, lumbal part. In fact, hindi ko ito ganun ka na-appreciate. But yung fetal back, ma-appreciate nyo talaga siya. If your patient is not obese, kapag advanced in AOG, maganda siyang gawin, no? Maganda siyang i-vote. Also, what your L2 will help you determine also is the fetal lie. So the fetal lie is kung yung axis ng baby, no? Kasi pwede siyang transverse. Pwede din siyang longitudinal. Pwede rin siyang oblique. Although very rare ang oblique. So ano po bang importance kung nakapahalang, naka-transverse si baby or naka-longitudinal? If transverse, guys, tapos term na yung patient, kung malaki enough yung baby mo, hindi siya ganun kaliit, and it's transverse, CS yan agad. Okay? Magmamatter kung ano yung position niya, later na yung position, pag nandun na tayo sa labor part. But for now, what's important for you to understand is kapag ang kapa mo sa L2 ay yung transverse lie, cesarean section yan. Okay? Sige. Now we move on to L3. We also call this pollix grip. So, for L1, L2, guys, ang position ng examiner is you are facing the maternal head. Okay? So, si L3, this is performed by grasping with the thumb and the fingers, one hand, the lower portion of the maternal abdomen above the symphysis pubis. So, aside from confirming kung ano yung presenting part, this also tells you if the head of the baby is engaged or not. Anong ibig sabihin ng engagement? Okay, ang engagement, guys, is if your BPD, your biparietal diameter, is already past the pelvic brim. Okay, so pag past na siya ng pelvic brim, engaged na siya, hindi na siya mobile, hindi mo na siya ganun ka magagalaw. But if it's still floating, mataas pa, dun mo siya ma-determine sa pollic grip sa L3. Okay, L4, so kung yung L1 to L3, nakaharap ka kay mother, when you do your L4, you have to reverse your position, you will now face the mother's feet. So you do this by using your 3 fingers of each hand, and then you exert deep pressure in the direction of the axis of your pelvis, of your inlet. Okay, so this determines the degree of descent, and at the same time, it also tells you if the patient, what the fetal attitude of the baby is. Okay, explain ko yung fetal attitude na yan. So, degree of descent, syempre, kapag halimbawa, mas mababa na siya, nag-engage na siya, nasa loob na siya ng pelvic ring, hindi mo na mapapag-meet yung dalawang fingers. So, one more thing that you have to note on L4 is your cephalic prominence. Okay, so your cephalic prominence, kapag nasa same side siya ng maternal back mo, it means that your head is extended. Okay? Na-imagine nyo ba? So if your cephalic prominence is nasa same maternal side siya as your convex hard structure or your fetal back, then ibig sabihin, naka-extend yung head mo. However, kapag fully flex yung baby, nasa same side siya as your irregular part on L2. Naget? So important din siya kasi, syempre ang gusto natin naka-flex yung baby when you descend into the pelvis para makapag-vaginal delivery tayo. Later on, I will also discuss that in the cardinal movements of labor. Okay? So that's your L1 to L4. I hope that's clear. So I have a question for you guys. So you have a multigravid patient, 31 weeks, so magandang time to do your Leupold's maneuvers. So occupying the fundus is a nodular mass with a hard convex structure on the maternal right. So nasa fundus, nodular mass. So breach, yung nasa fundus mo. Hard convex structure on the maternal right. By the way guys, when we see right, obvious na yan na maternal right. So minsan pag nagdadrive ako, minsan nalilito ako sa direction kasi. I turn left, right, because the maternal right is this one, maternal left. Okay, yun yung orientation. Okay, yun yung orientation minsan ng utak ko. So when you see right, obvious maternal right is what you always refer to. So yung convex structure na hard, meaning your fetal back is on this side, maternal right. And on suprapubic palpation, there is a round ballot ball mass, so cephalic yun nandito. So yung L3 mo, it confirms your L4. So sa quadrant ka, likely makakarinig ng heart tones. So likely mas makakarinig ka dito sa right lower quadrant, where your head is. Siyempre kapag nasa taas yung ano mo, kapag reach yung presentation mo or cephalic yung nakapa mo on L1, siyempre nasa upper quadrant yung heart tones mo. And then yung kung nasaan ang fetal back, doon ka mas makakarinig ng fetal heart tones. Okay, so ito, right lower quadrant, based on Malupol's maneuver results or findings that were described in the question. You get? Okay. Let's move on. So since I already mentioned this, so another important part of your physical examination is your fetal heart tone. So speaking of fetal heart tone, kailan mo siya unang manonote? So the earliest that you can note this is on transvaginal ultrasound at 6 weeks. So makikita mo yan, cardiac motion. There is flickering already on ultrasound in your 6 weeks EOG patient. Pag Doppler ultrasound, anong Doppler to Doctoria? Doppler na ultrasound, hindi guys. Doppler as in yung Doppler na nakikita nyo sa clinics namin, yung mabibili nyo sa Shopee, that Doppler. At 10 weeks, if you have a good Doppler ultrasound, narinig mo na yung FHT. At 20 weeks, using your standard non-amplified stethoscope, meaning kung ano yung meron kayo, yung cardiac stethoscope, most of you will already hear the FHT, especially when you use the bell. Okay, masusunod natin yung bell rather than the flap or the diaphragm of your stethoscope. Mas maririnig nyo yung heart tones with that. Pero in all women, pag 22 weeks, dapat maririnig mo na siya. So hindi pwede excuse ng interest. Sorry, yung matamit kasi yung ano ko tamit po yung stethoscope ko. Pero tapos yung patient mo ay 24 weeks na, 28 weeks na, hindi, maririnig mo yan dapat. You just have to look further baka naka-close yung bell mo when you're auscultating. So 22 weeks, dapat sa lahat makakapag-FHT monitoring na kayo using your own stethoscope. Okay. So now let's move on to the sonographic findings of pregnancy. So ang first na evidence mo ng pregnancy is your gestational sac. So this is a drawing, this is a representation of your gestational sac that is implanted inside the uterus. So ang description niya sa gestational sac, so it's this one, it's an anechoic na regular siya na mukha siyang fifth, diba? When you see kasi echoes guys, pag ultrasound, we describe it in terms of echoes. Pag anechoic, meaning walang nagre-reflect back ng sound, so black lang siya. So ito siya, anechoic. Kapag white, ang description naman hyper-echoic. So maraming nagre-reflect back ng echoes. Okay, kapag medyo grayish naman siya, hypoechoic siya. Okay, so ito anechoic cyst siya na eccentrically placed. Ano yung na eccentrically placed na gestational sac na structure? When you see eccentrically placed, it means wala siya sa midline. Because as you can see, your gestational sac, it implants either on the anterior, posterior, basta hindi kasi sa gitna. Okay, why is it important to note? Kasi merong tinatawag na pseudo-gestational sac. By the way guys, yung gestational sac, as early as 4 to 5 weeks, you can already note that on your ultrasound. That's why it's the first sonographic evidence of pregnancy. Meron kasi nakakalitong image. So this is your pseudo-gestational sac. Kung papansin niyo irregular siya, hindi siya bilog na bilog, and it's right in the midline. So when you have this, it means na may fluid collection ka sa gitna ng uterus mo. So hindi siya nag-implant anywhere. So where do you see your pseudo-gestational sac? This is one of your typical findings of in ectopic pregnancy. Okay, na-get? So ito binhi. So gestational sac, this is a good sign for you. But when you see this, you can label this as gestational sac. So una sa lahat, irregularly shaped siya, and then gitna siya. So pseudo-gestational sac siya. So the next finding that you will find, so based on God's design, we are given the structure first before we come to form. Okay, so yolk sac becomes the temporary form of source of nutrition of your future embryo. So ito siya guys, it's a regularly shaped na circular structure inside your gestational sac. So dyan ang gagaling yung source of nutrition. So anechoic din yung kanyang inside, and meron siyang hyperechoic din. So that's your yolk sac seen between 5 to 6 weeks or 5.5 weeks. So after your yolk sac, saka maka-form the embryo. So as you can see, ito si yolk sac, which is the source of nutrition, and then this is your embryo. So that's your embryonic plate. So this will eventually become the fetus or the baby. Okay? So ito siya. So at 6 weeks, dapat may cardiac motion ka na, may flickering ka na naman on transvaginal ultrasound. So one note again about ultrasound. So kailan kami transvaginal ultrasound, kailan pelvic ultrasound or transabdominal ultrasound. So 12 weeks and below, since nasa loob pa siya ng pelvic vein, hindi pa siya abdominal organ, transvaginal pa yan. But beyond 12 weeks, doon na kami nag-transabdominal scan. Okay, nag-get? Let's move on. Now, this is another unique physical examination that we do as OBGYN. We perform internal examination and speculum examination. So the way we describe it is from labas paloob. Okay, so we start with the external genitalia. So kung wala namang anything abnormal, normal external genitalia. And then when you insert your speculum into the vagina, you will note that there are no masses, so smooth, callous vagina. So we have a video demo of the speculum and internal examination. So please watch this. Okay, going back to the cervix. As I mentioned, marami tayong ways to describe the cervix, lalo na pagbuntis. Okay, so sa buntis lang to guys ha. Actually, this mnemonic, this is my mnemonic for your Bishop's Fort. These are your components of the Bishop's Fort. But basically, pag nag-AI ka, ito rin naman hahanapin sa inyo. So I will be teaching you this mnemonic already. So isipin nyo na lang, when you're pregnant, you have to call PEDS. You have a pregnant patient, call PEDS or pediatrics. So C stands for consistency, P is for position, E is for your effacement, D is dilation, it's the same as dilatation, station is your last component in your Bishop's scoring. Okay, so ito yung ito yung most complete way of describing cervix for us, OBY. So isa-isahin natin yung isa. When you see consistency, it's the texture of the cervix on examination. Again, this is subjective guys. Firm, medium, soft. Tatlo lang naman siya. So if it feels mushy already, then that's soft. So hindi ko makakalimutan na sinabi ng resident in charge when I was clear. Sabi niya, ito daw yung firm, ito yung medium, the tip of your nose, and then your lips, that's soft. Okay, so that's for your consistency. I never saw that in any book. I never heard it from anyone else. But that's one good way or parang one subjective way of describing it to someone who will be doing IE for the first time. Okay? Next is your position, diba? Called P. So P, tibia. So your position, you can describe it as anterior, mid-position, posterior. So ano yung dinidescribe niya? So yung dinidescribe niya is the position of the cervix against your presenting part. So if it's more towards the symphysis pubis, this is your mons, the symphysis pubis, the part, the bony pelvis, on the area of your, near the area of your mons, that's anterior. Pag doon mo nakapa yung cervix. Pag mas close naman siya to your sacrum, then posterior siya. Okay? So imagine niyo ba, if this is the head, the presenting part of your baby, and your cervix is anywhere along this axis, that is how you will describe the position of the cervix in relation to your presenting part, usually your head. So the next component in your IE is your effacement. So effacement is how thin out your cervix is. So kapag uneffaced siya, it's around 2.5 to 3 centimeters long, mahaba. Yung sinasabi namin makapal pa dok yung cervix niya. Pag sinabi namin manifest ng cervix na going towards the fully effaced spectrum of description. Pag sinabi mong fully effaced, 3% na yung cervix mo. Okay? So kung gano'n ka-thin out yung cervical length mo, so mas naninipis siya. Imagine nyo ba? It's hard to describe, pero usually ang ginagawa ko ay I use as a reference this, my index finger, so this is around mga 2.5. So kapag yung length ng endocervical canal mo is as long as your index finger, makapal sa doktora yung cervix. Okay? So half of this, 50% effaced, okay? Tapos kapag sobrang nipis na fully effaced, okay? Don't quote me on that one, okay? Sa totoo lang guys, ang internal examination, it's a very subjective examination. But across all OBGYN, sa mga pag-duty ko, and even my more senior or even my more junior obstetrician friends, parang parehas naman kami ng IE, or nagkakaintindihan kami at least ng IE, even though it's a very subjective examination. No? So yun yung ano ko, that's how I take note of effacement. Okay? But basically, efface means makapal pa siya, mahaba pa yung endocervical canal mo. Pag fully effaced na siya, your presenting part has already thin out, like this one. It has already thin out your cervix to the point na halos 3% na yung ng cervix mo. Okay? So next, Paul Fields, next is dilatation. So siguro ito yung pinaka-popular no, na description ng cervix. So 1 cm, 2 cm, 3 cm, 5 cm, lahat yan estimation lang guys. So kapag nakapasok yung 2 finger breadths at around 2 cm, isa lang yung napapasok mo 1 cm. Pag hindi mo siya napapasok yung fingertips mo, it's closed. Okay? Ang fully dilated, yung ulo na lang yung nakakapamo. Wala ka nang nakakapamo cervical rim. Ulo na lang. So it's a bagel. Okay? So in terms of food, ito yung food guide to cervical dilatation. But essentially, without memorizing this, ang full cervical dilatation kapag wala ka nang ibang nakakapa, but the presenting part of the patient is already fully dilated. Okay? So, sige. So, ito yung, as I mentioned, ito yung parang, ilang cm patient mo? 2 cm, doktora. Just take note, guys, na ang tinitingnan namin dito is the dilatation of your internal os. Remember your cervix? If you can see this, no? Ito yung cervix mo na uneffaced. Dalawa ang opening niya. External os and your internal os. Itong opening na to, itong dilatation nito, yun ang dinidescribe namin, rather than the external os. Why? Because if you have a multiparous patient, minsan bukas na bukas to, guys. So, magkakamali ka minsan ng i-describe. Ang i-describe mo talaga, yung ito, yung internal os. The one that is nearer to your presenting part or to the fetal head. Okay? So yun yung i-describe natin, how open this opening is, this internal os is. Next, speed. So next is your station. So station is describing to you the level of the descent of the head, okay, or the lowest presenting part, the most dependent presenting part. So when your anatomic landmark for this is your ischial spine. So when you do your pelvimetry, may makakapakang parang pagtusok sa along the vaginal wall, that's your ischial spine. And that's a marker, that's a very important anatomic marker or landmark. So pag nandiyan na yung presenting part mo, the patient is at station 0. The head is at station 0. That's how we describe it. So anything above your ischial spine, so above meaning mas paloob, mas pataas, okay? So ito yung umbilicus mo, anything towards the umbilicus, pataas, negative, negative 1, negative 2, negative 3. Pag mas mababa sa ischial spine, positive. So 0 to 2, 4, plus 4. So pag counting na yan, 4 plus 5 na yan, okay? Call your resident or ikaw na magpaanak yan. Alright? So another important point why we have to know where the ischial spine are, dyan din yung marker namin for the pudendal block, okay? Yung ischial spine mo. What else regarding the ischial spine? So as you notice, dito sa pelvic cavity niya, after the, okay, siguro, before it reaches the outlet, ito yung area with least dimension, okay? So kung papansin nyo, medyo wide open yung pelvic rib, pero ito yung pinakamakipot niyang dadaanan. So later on, when I describe the cardinal movement to you, makikita nyo bakit kailangan mag-rotate yung ulo to the anterior or posterior at the level of the ischial spine, alright? Sige, we'll go back to that later on. Now we'll go to the labs and medication or others. So yung medication, hindi ko masyado yung tinouch on, but the labs, sige, I will touch on it. So ito ang mga kailangan nyo i-request for the patient. So we're done with the history, we're done with the TB. Ngayon, utusan ka na ng resident, okay, order labs for the patient. Okay, so ito, pag first visit niya, these are the laboratory na typically in order natin locally. So CBC, to check for anemia, blood typing. Bakit important yung blood typing, guys? Bukod sa pwede kasing mag-transfuse during pregnancy or during labor even. Bukod doon, you have to check for the presence of your RH. Okay? Kailangan important sa amin kung RH negative or RH positive yung mother. It matters to us kasi magbibigay kami ng immunoglobulin kapag RH negative. So most of Filipinos naman RH positive, O positive, AD positive, B positive. But we have a rare patients, we have RH negative patients. So later on, I will explain why this is significant for us. And then we do pap smear. So pag nagpa-pap smear ng buntis, this is opportunistic screening for cervical cancer. Yun lang talaga siya. Okay? SBS, we do this during the first visit. Paano kung ang first visit niyo, Doctora, 24 to 28 weeks, you go straight to your 75-gram OGTT. Okay? Doon tayo sa 75-gram OGTT. Mamaya explain ko to further, bakit 24 to 28 weeks. Next is urine culture. We don't order urinalysis. The preferred is urine culture. Pero since it's expensive, some OB opt to perform urinalysis. But it should be urine culture. That's what's in the book. Next is your hepatitis B infection screening test, which is your HBsAg. Next is rubella antibody screening. So if you have protection against rubella. Next is you have to screen for syphilis. So we can do this by requesting RTR or DDRL. At HIV serology, we offer this. May opt-out option kasi for HIV. And then your GBS culture, we swab the rectovaginal swab or RDS, sorry, redundant, at 35 to 37 weeks, okay? This matters kasi pag ito na positive, we give prophylaxis against your GBS, okay? Or your group B streptococcus. Alright, so other than your laboratory test, so these are the things that, these are the imaging that we order. That's vaginal ultrasound within the first 12 weeks. After that, biometry. Biometry, mini-measure mo si baby. Thereafter, you can add your biophysical profiling. I will discuss this in detail later on at 28 weeks. So pagpapunta ka na ng third trimester, we already include this BPP. So next, doctor studies, as I mentioned a while ago, kapag may comorbid condition si mother, if there is any predisposition for her to have uteroplacental insufficiency, we check the Doppler studies of the placenta and the arteries, okay? congenital anomaly scan, this is needed. So itong naka-asterisk na to, as indicated lang siya. So when do you do congenital anomaly scan? So there are multiple instances. For example, you have a previous baby with a congenital disorder. So you do that. Second, probably kapag nakapag-alcohol intake during the first trimester, okay, we do CAS also or targeted anomaly scan. Next, for example, 35 years old. Okay, so that's also one reason why we tag elderly preemie gravid. Okay, or actually technically preemie gravid. So 35 years old and above, we offer congenital anomaly scan. So para pag wala naman ng mga risk factors, ganyan, wala family history, wala naman kung intake ng any teratogenic medication, pwede bang magpa-congenital anomaly scan? Pwede naman po. But this is relatively expensive and we usually do this 18 to 20 weeks. So may window period. Pwede pa rin gawin beyond 18 to 20 weeks pero we offer the patient and we tell them kung gusto nila, timing nila ng maayos at 18 to 20 weeks. Alright? Sige, kasi mahaba, mas mabusising examination kasi ito ng for your baby. Okay, so this is what I am mentioning when I say that we have to do blood type. Because you can have RH incompatibility. Ngayon, may dalawang kinds of incompatibility, alloimmunization from na based sa blood typing. ADO incompatibility, this is more common pero this is less severe. So this happens when the mother is O, yung blood type niya, and the baby is A or B. So no desensitization needed. So yung first baby pwedeng ma-affect. Mamaya sasabihin ko sa inyo kung ano yung sensitization na tinatawag. So since hindi naman kailangan ng sensitization for your ADO incompatibility, pwede ma-affect si first baby. So yung babies na to, they can present with mild anemia. To be honest guys, itong ADO incompatibility, hindi na to nare-refer sa amin. More of yung pedia, yung mga na-manage ng cases of incompatibility. So ano yung mas pertinent sa aming mga OB? It's the RH incompatibility. So if you have an RH negative mother with an RH positive baby, your baby could have severe anemia from the RH incompatibility. So there will be alloimmunization. It means that the mother's body will fight off the RH positive blood type of your baby. Okay? So sensitization is needed for this. So meaning, kapag na-expose sa RH antigen yung mother the first time, mapapalampas pa yan. Okay? The first baby is safe. This is for the G1. But for the succeeding babies, your mother will already have antibodies against the RH antigen. So kapag nagkaroon siya ng second baby na RH positive, the mother could there could be an alloimmunization between the mother's blood and the baby's blood pag naghalo yun. So this will result to anemia in the baby. So this is more severe, okay? Fortunately for us, among Filipinos, this is not as common, the RH negative mothers. So, okay, so ito yung sinasabi ko guys, RH incompatibility and alloimmunization. Sa first pregnancy mo, si baby, di ba, meron siyang RH antigen. The baby is positive. Si mother, since wala RH negative siya, she will form antibodies against the RH antigen of the baby. So pag first baby, pag kapag halimbawa siya ay na-deliver and na-expose, and there's mixing of the maternal and the fetal blood, that's when the mother will form antibodies. Okay, so lalabas ng walang problema yung first baby mo. However, in the next pregnancy, kapag nagkaroon ulit ng mixing ng blood either during labor, during times of obstetric hemorrhage or preterm labor, kapag halimbawa nagkaroon ng mixing ng blood between the baby and the mother, the antibodies of the mother that were formed during the first pregnancy will fight off the RBCs of your baby. That's why the second baby of those RH negative mothers with babies na RH positive for their G2, yan, dyan na nagmamanifest yung RH incompatibility. Nag-get?